Good evening and welcome to today's special broadcast on World Sepsis Day. Hi, I am Shrestha, your host for today, and with me I have a distinguished guest, Dr. Mahua Dasgupta. Dr. Mahua is a Director Medical Affairs at HaystackAnalytics and a leading microbiologist with extensive experience in hospital infection control and patient safety. She has been at the forefront of infection management and is here today to shed light on the life-threatening condition that kills millions of people worldwide each year. Thank you so much for joining us today, Dr. Mahua. So,
Thank you.
to start off, I think we should address a basic question first. What exactly is sepsis, and why is it such a serious health concern?
Thank you for this opportunity, Shrestha. It is a subject which has always been very close to my heart. The reason why, because when I was training for my post-graduation, this was my thesis topic as well. So I really wanted to make a difference in this. Sepsis is, and while this story of my working on a thesis dates back to nearly 15 years, this still seems to be a global challenge with 49 million infections and 11 million deaths. It is, in fact, the leading cause of death, not only in hospitals, but also one of the most important causes of death in the community. What exactly is sepsis? Sepsis is actually a host response. So when I say the host, I mean the human host. So it is the body's response to an infection, which if within limits actually takes care of the infection itself, but if goes awry, then that becomes a killer. So it is a disrupted immune response to infection anywhere in the body. That is sepsis.
And why do you think it is such a serious health concern? Like, why does it bring us to the kind of fatalities that we know of?
I think the high morbidity and mortality associated with sepsis is what makes it so threatening. So many of these cases, even when they have been successfully managed in the hospital, led to readmissions within 1 year of their discharge. Sepsis is that bad a condition because it puts your immunological system, your fighting capability, your defense mechanism to infections haywire. Second is the mortality. The mortality is very high because when your body starts reacting against self, so when I say an immunological response gone haywire, it means the body, the defense is working against self, and it starts affecting all the major organ systems in the body, which starts failing. So what happens is an infection, which if early diagnosed or treated, could have been limited, when it moves to the phase of this disruptive immune response, becomes very difficult to be treated. And that leads to a very high incidence of morbidity as well as mortality. That makes it threatening.
So, how does something like as in infection? Like infection is something which is very common among us, right? So, how does an infection become so deadly as sepsis? And I think you have already covered how it brings us to the fatalities that we know of, the morbidity of it. But if you can take us through some examples of what you have seen over a period of time in your, of knowing sepsis.
So, Shrestha, when we talk about infections, they are abound. Almost all of us every year face a lot of those, which seems to be taken care of by themselves without we even taking cognizance of it or going to a healthcare system. Then why is it that some of them seem to end up with such severe fatalities? Are they a group of infections? Are they a group of people? Yes, to some extent, yes. There are certain infections which have a tendency to move into the direction of sepsis if not taken cognizance of early and treated well. And some of these are pneumonias, which in the common language we call as lung infections. Then intra-abdominal infections like the diarrheas and the dysenteries that we often see. Then we have the urinary tract infections, many UTIs, which can take into such gruesome forms. So these are some of the infections, apart from, of course, some surgical site infections, some wound infections, skin and soft tissue infections. They are also there, which can lead to sepsis. Predominantly, these are the ones. Again, there is a host predilection. Not everybody will go into sepsis. So there is something in the genetic makeup which is being studied, and people have found some genetic polymorphism in certain hosts, which can lead to their higher predilection for going into these complications of infections. So that is also there. So some people are more predisposed, right? So there is also a concept of higher risk groups. So when we talk about these groups, what we mean is these cohorts are more predisposed and at a higher risk of developing. That includes the extremes of ages, like the neonates and the elderly. It includes the pregnant females. It includes the immunocompromised, people who are either on some medication which depresses their immunity for a different cause, or maybe suffering from some malignancy or some other infection like HIV, which has depressed the immunity. These are the risk groups again, where a simple infection may take on the form of a sepsis.
Right, right. So, can you talk about some of the common symptoms or clinical markers of sepsis that can give us an idea of the progression of this disease?
So I'll take the example of my previous workplace, where I was working very closely with the level 3 neonatal ICU, right? So as I mentioned, they are a high risk groups, and with especially the low birth weights, the very low birth weights and the preterms, they run a risk of developing sepsis out of an infection. And many a times we have seen that such infants, while are probably progressing and doing well, all of a sudden would end up with symptoms like sudden drop in the body temperature, mottling of the skin, a respiratory distress, distension of the abdomen. These are features which we see in neonates when sepsis affects them. And probably the starting point was UTI, which developed during their stay in the ICU. While there are cases where there is an elderly who's been at home and maybe a 70 plus year old male who suddenly has developed symptoms of fever and cough at home due to some viral onset, some lung infection, and very rapidly had to be shifted to a hospital with respiratory distress, sudden fall in the blood pressure, mental confusion, cold, clammy extremities, a very high heart rate, a very high respiratory rate, and they had to be intubated and put on pressor therapy, that is maintaining their blood pressure with supports. So this sudden downfall from a simple viral pneumonia progressing to the symptoms of sepsis.
Right, right.
Which ultimately sometimes do not respond and can even lead to what we know as refractory shock, where any amount of external support is also failing to maintain the blood pressure with medication or with fluids. When such a thing happens, the blood supply to many of the organs are disrupted. Apart from that, this immunological, the chemicals being released because of the disrupted immunological system also goes and ends up damaging various organs. So there is a multi-organ system shutdown. So you will find the liver has failed, the parameters are getting deranged, the urine output has stopped. So there is a kidney failure happening. There is a heart failure, there is a respiratory failure happening. So the multi-organ affection is seen then. This is the progress.
Right. Well, that was very insightful. Like the progress is very important for us to know, actually. And this actually also brings us to the diagnosis part of it. So, how can timely and accurate diagnosis of sepsis save lives? And what are the diagnostic challenges that we are facing, like currently worldwide?
See, if we want, one is preventing sepsis, the other is diagnosing sepsis. Okay.
Right.
If we want to prevent sepsis, we need to diagnose infections earlier. And then comes the concept of diagnosing sepsis itself, where the progression has already happened, right? So diagnosing a sepsis in itself has delayed our response. So either the patient has reached the healthcare facility really late, while all along there was an incubating infection in the person. They came to the facility only when the symptoms got more drastic, right? So at that point, it is a suspicion. And at that point, sometimes detecting the source of infection becomes a huge challenge, because by that time, all your organ systems have gone for a toss. And when there are such multiple systems affected, pinpointing infection becomes very challenging. The other challenge is there are a lot of conditions in medical science affecting humans which are strong mimics of sepsis. Even a heart failure can mimic sepsis.
Right.
Right? So the best way is to prevent sepsis, which means early diagnosis of infection. To reach out for healthcare at the hint of an infection is important, so that it never progresses to sepsis. Especially the risk groups that I mentioned, it becomes very important to take proper cognizance and make facilities available to them for early detection of infection.
Right.
So traditionally, whenever we have tried to prove infection, we are simply actually chasing the Koch's postulates. That is Robert Koch, who introduced microbiology, and it was his teachings which led us to the concept of showing the presence of a microorganism which can cause an infection. So we have to show what is causing the infection. This showing is very difficult with traditional microbiology. The methods we resort to leads to one, prescription of a number of tests; two, the resources available in a laboratory; three, the skills available; four, it is very hypothesis driven, which means that a clinician and a microbiologist have to enlist the probable causes; and five, if I have to show, the best way to show is to grow, and we can't grow them always in the lab. So these are real life challenges when we go on to prove an infection.
Right. So, what are the processes that you would, go ahead with when it comes to diagnosis? Like, if you can take us through from identifying it to the diagnosis part.
Okay. So let's again talk about an example. Let's assume the example that I said, an old man being wheeled into the emergency. And what I see is he's sweating. There are cold, clammy extremities. The heart rate is very high. The respiratory rate is very high. He seems to be gasping for breath. And I see an obtunded male. He's mentally confused, not very coherent. In fact, we are probably going down on the consciousness level. And the family says that for the last 2 to 3 days, he's been coughing on and off. He's a known hypertensive and a diabetic, and he has been on his medications. He passed urine once in the morning, and that's it. After that, he's not been passing urine as well. So when I, as a clinician, am trying to list down the causes, one of the foremost cause in my mind definitely will be a lung infection, as I mentioned, pneumonia. But at the same time, I will also have the concern of a heart failure. Okay, I think I'm not going into the elaboration of, there are many more causes. And there is a lot more history that we need to take, but let's go ahead just with these two. So accordingly, we would prescribe certain tests at that point. Why? Because I'm going to try and rule out and limit my differential. So in that ruling out, if I have to check for pneumonia, I probably will advise a chest X-ray. I'll go for a CT chest. I will also do accounts on the blood. So the routine pathology, I will also try and see and assess the status of all his organs. Now that I hear that he's not passed urine, so probably I'll have some biochemistry tests like the kidney functions. If it is infection, has it progressed to sepsis and what stage it is in? I will also do an arterial blood gas. So I'm doing a lot of things when I'm trying to narrow down my diagnosis. Alongside an echocardiography and ECG, because somewhere heart failure is on the list, I will do a TROP-T, and there are a number of other tests which I will be employing to find out what is the cause. Specifically, when I'm trying to look for infection, what I will do is, if I have to prove pneumonia, first I have to think what are the probable agents which can cause pneumonia in this old man who has been residing in this area. Is there a viral outbreak going on in the city? Which are the probable viruses? Do I have those tests available with me? Is the patient affording enough so that I can write those tests and find out whether the cause is a viral cause? Again, will those tests cover some of the bacteria which might be again a cause of this suspected community acquired pneumonia? Alongside, is the patient able to produce enough sputum, or am I able to draw out some sputum from his lungs which I can send for a microbiology culture? And when I send, I will also request the microbiologist to perform something known as a gram stain, like do a microscopy and tell me whether you are seeing any inflammation in the lungs. This is the diagnostic workup that we create. So there are the pathology tests where we see hints of infection. There are the biochemistry tests where we again see hints of inflammation and the organ conditions. There are the radiological tests where we assess the status. And then there are the microbiology tests where we are trying to pinpoint the organism. But there are a number of tests for different organisms because they are very pathogens causing such infections are very choosy in what they want for them to reveal themselves.
Right, okay.
So a bacteria may grow, but a virus is not going to grow easily. So I'll need some other test to find out a virus. A fungus, on the other hand, may say, I will grow, but I'll take my own sweet time to grow. Amongst the bacteria, again, the choices are different. Somebody wants an oxygen, somebody wants a carbon dioxide, somebody doesn't want any air around it.
Oh, okay.
So we have to serve their needs for us to identify them. That is the challenge of traditional microbiology.
Right. And would you be able to take us through some of the misconceptions regarding this disease before we go into what we have innovated in this sector?
Sreshta, very honestly, the time that I have spent as a clinical microbiologist and prior to that as a medical graduate, what I have seen is we have a tendency to label everything as a sepsis. We never somehow want to reconsider the diagnosis. If I've thought of sepsis, I'm hell-bent in trying to prove that it is an infection. Somewhere we also need to keep in mind the non-infectious causes which can mimic sepsis. It is an important thing to consider. And accordingly, order, prescribe, and get those tests done, which can rule out those other conditions. Otherwise, what happens is we waste a lot of resources trying to prove infection. Not only that, we expose patients to a lot of antibiotics, and that too broad spectrum ones. Yeah. While I understand that such empiric therapy is inadvertent because we need to save the lives. So we need better diagnostic stewardship somewhere where the negative predictive value of a test is very high. If some test can say that the infection is not there, we are at a better place to go ahead and consider the other causes, the differential diagnosis of a sepsis.
So now that brings us to where we are today. So can you take us through how, what do you feel genome sequence approach has contributed? Like, how has it contributed to the diagnosis of sepsis?
Okay. I'll again take you back to my to the period I spent with the neonatal ICU. When such samples would be sent to us, at that time I was working more so with the traditional methods, and I would be assisting the clinical, the intensivist, the neonatal. There is an infection and what is causing it. I would see that there are a number of tests which need to be done for me to be able to give a relevant answer, to be able to not only that, my sample volume from a neonate is so less and come up with reliable answers. And I would often wonder, can we have a single test solution which can give me a comprehensive answer, which is pathogen agnostic, which is not directed by the whims of the organism, but has the capability to detect from the sample at one go what is there, and which can happen at an affordable way within a turnaround time, which can impact clinical decision making. So that was the time when I got exposed to something known as sequencing technologies in diagnostics. So sequencing technologies have always been there all through these years, more than 50 years now, but it has always been more so in the arena of research. And it has been widely used in microbiology. The very interesting part is all these organisms and pathogens we are talking about, which are creating such a mess in our lives, it has always been sequencing, which was used to identify, to predict, to classify, to understand an organism better. But it was never ever used for real-time clinical diagnostic solutions. When I was introduced to this, that this is now feasible, with the advent of next generation sequencing, we can have a test which can be comprehensive, which can be accurate, which can have a small turnaround time at a cost which is affordable for our country. And why do I mention our country? Because infection, if you see globally, is still a concentrated burden for the LMICs.
Yeah.
So we have to take, again, that into consideration whenever we are coming up with a novel technology. The affordability, the accessibility of such a technology for these countries where the burden is high.
Yeah.
So this was feasible. So it is a dream come true that now I can, if I'm suspecting a meningitis, that is a central nervous system infection in a neonate, or if I want to screen it for any bacteria or any fungus without having to bother whether I'll be able to grow it. And since I have a very low volume, at one go I can screen for everything. That is what is the need of the hour, I would say. And that is the technology that now I'm working with.
I think that is fantastic news for everyone. That we have come to this place that we can do, we can reduce the turnaround time as well as keep the budget to what affordable to everyone in this country. This brings us to our last question. Before we go into diagnosis, and we always believe that prevention is better than cure. So if you can give us some insights on how sepsis can be prevented in the first place, that would be great.
Sepsis can be prevented. So how preemptive can we be in preventing sepsis? One is early diagnosis of infections. That is one way in which we can preempt. The other is preventing infection itself. So if we have to prevent infection, there are certain very basic things we need to do. And I think our culture, our tradition holds those views strong for ages. Washing hands, covering the mouth and nose, giving enough rest, sleep, good food and a diet, safe drinking water, good sanitation. These are certain basic tenets of preventing infections. Of course, vaccination plays a huge role, right? These are to prevent infections. That is one aspect. We have got a taste of it with the recent pandemic. Simple measures which could keep the pandemic at bay. The other part is the early diagnosis, which is a kind of secondary prevention, you can say, but of course, it's a primary prevention for sepsis. So if we can detect infections early, which means that the awareness to come to a healthcare instead of over-the-counter medications, instead of dilly-dallying at home, coming to a healthcare, getting it sorted as early as possible, resorting to diagnostics, which again, as I said, is pathogen agnostic, knowing what is there and ruling out if it's not there. That is what we need to prevent the progression.
Well, thank you so much, Dr. Mahua, for your time and the valuable insights that you have shared with us on this critical topic. And we all know now that, and we agree that early detection is a key to survival, and raising awareness would be definitely the first step to combat sepsis. And we hope this conversation reaches as many people as possible, and we can bring down sepsis together in India. Thank you.
Yes, Rishta.